As promised earlier, let's talk now about a disease that causes an increase in HCG production, the hydatidiform mole. You can think of it as a fertilized egg that wasn't able to form a normal zygote and begin to develop. Instead, you get a cystic swelling of the chorionic villi and proliferation of the chorionic epithelium. As the name implies, gestational equals pregnancy and trophoblastic equals in the placenta, so it's a disease that occurs during pregnancy that involves growth in the placenta. In terms of question stems, you should suspect a hydatidiform mole when a pregnant woman presents with vaginal bleeding, with or without anemia, morning sickness that extends beyond the first trimester due to persistently elevated levels of HCG, or hypertension before 20 weeks of gestation. So what would you think if hypertension came after the 20th week? Hypertension later in pregnancy would most likely be preeclampsia, right? You would also think of a hydatidiform mole if the patient has a uterus bigger than what would be expected given the gestational age. As seen in this CT, the patient has an enlarged uterus that's larger than expected. Oh, and just for reference, remember that at 12 weeks, the uterus should reach the pubic symphysis. At 20 weeks, it should reach the umbilicus. The classic way to diagnose hydatidiform mole is by ultrasound, where you have a characteristic snowstorm appearance. These two images show an endovaginal and sagittal ultrasound, both showing the heterogeneously echogenic mass with multiple hypoechoic foci consistent with molar pregnancy. Snowstorm appearance on ultrasound is another one of those medical buzzwords that's worth knowing because it's always used in this context. Moving a little further, the next thing to think about when getting a question on moles is whether the mole is complete or partial. So what does that mean? A complete mole occurs when a 23-chromosome sperm joins an empty egg. As the egg has no chromosomes, the 23 chromosomes in the sperm duplicate, resulting in a zygote that is 2 times 23. While the slide says the 2 sperm form a complete mole, keep in mind that it's originally 1 sperm that unites with the egg that later divides, giving you 46 total chromosomes. A partial mole occurs when 2 sperm join 1 egg to form a 69-chromosome zygote. Both will have increased beta-HCG and have some risk of converting to choriocarcinoma, which is a very aggressive type of cancer of the placenta. However, this risk is significantly higher in a complete mole. They're both treated the same, with dilation and curettage, and with methotrexate. After treatment, further monitoring is done by checking the beta-HCG levels, which drop back down to normal by 3 months. So what should you be worried about if the beta-HCG level does not go back to normal? Well, again, you have to worry about choriocarcinoma. Choriocarcinoma can occur anytime there's pregnancy, including ectopics, miscarriages, but most commonly with moles. So here's a pretty high-yield segment for you. Preeclampsia is relatively common, occurring in about 7% of pregnant women. The clinical presentation includes the classic triad of hypertension, proteinuria, and edema. Its cousin, eclampsia, is simply preeclampsia with the added symptom of seizures. It's also worth noting that you're at more risk of developing pregnancy-induced hypertension if you have pre-existing conditions like hypertension, diabetes, chronic kidney disease, or other autoimmune disorders. The causes of PAH are not really that clear, so in other words, they probably won't be tested on the boards, but the mechanism is generally accepted to be placental ischemia in the setting of uterine spiral arteries that cannot vasodilate. This may occur if the placenta is shallowly implanted. In terms of presentation, you may see preeclampsia or eclampsia along with HELP syndrome. HELP is an acronym for hemolysis, elevated LFTs, and low platelets. Some of the other symptoms of this syndrome include headache, blurred vision, abdominal pain, swelling of face and extremities, altered mental status, and hyperreflexia. The treatment for these patients is to deliver the fetus as soon as possible. However, if that would be dangerous to the fetus, or if the mother does not want to deliver early, the best course of management is to keep the blood pressure down with bed rest, salt restriction, and antihypertensives, especially hydralazine. If you have seizures, you want to treat with IV magnesium sulfate and diazepam. There are a few more pregnancy complications you should know. Some of the more common abnormalities represent a big area of focus for the boards, so let's talk a little bit about a few that show up most frequently. Abruptio placentae is the premature detachment of the placenta from the uterine wall that can cause painful bleeding during the 3rd trimester. The condition unfortunately proves fatal to the fetus about a third of the time. It can also cause maternal death in the worst cases. It can also lead to DIC in the mother. So how does this happen? During the abruption, you get tissue factor from the placenta into the maternal circulation, which sets off the extrinsic coagulation pathway and converts prothrombin to thrombin. In terms of risk factors, you worry about this condition in patients who smoke, have high blood pressure, or use cocaine. Placenta accreta occurs when the placenta invades the myometrial wall of the uterus, digging deeper than it's normally supposed to. When it comes time to deliver the baby in the placenta, it's basically stuck, and removing it can lead to massive bleeding. This occurs more often in patients who have had a prior C-section or who have had placenta previa. So speaking of which, what's a placenta previa? This is when the placenta attaches to the lower uterine wall, possibly blocking the internal os, which is the exit to the cervix. So you can think of this as the placenta wanting to be delivered pre or before the fetus. This is another major cause of late second and third trimester bleeding, but here you have painless bleeding, compared to abruption, where you get painful bleeding. Keep this distinction in mind. It'll serve you well on boards questions. Multiparity, or having lots of babies, and prior C-sections are risk factors for placenta previa. Sometimes the placenta gets out of the way before delivery, but if it doesn't, then you need to think about doing a C-section to ensure a healthy baby and mother. Another very common problem that often shows up on step 1 is ectopic pregnancy. Ectopic pregnancies are pregnancies that implant outside the uterus. The word ectopic in medicine in general refers to something that isn't where it's supposed to be. It comes from the Greek prefix ek, which means outside, and topos, which means place. So basically, it's out of place. The fallopian tubes are by far the most common location, but you can rarely see them in the ovary, cervix, or inside the abdominal cavity. In terms of the clinical presentation, you often get appendicitis-like symptoms, such as abdominal pain and fever about 6 to 8 weeks after the last menstrual period. There may or may not be bleeding. Of course, one of the major ways to rule this in or out is to do a urine HCG test. I have a high suspicion of ectopic pregnancy in any woman of childbearing age who has a history of infertility, salpingitis, or pelvic inflammatory disease, prior ruptured appendix, or prior tubal surgery. Lastly, in terms of pregnancy complications, if some of the placental tissue does not make it out, it can cause postpartum hemorrhage and significant blood loss from the mother. Just something else to keep in mind. So obviously, in addition to the placenta, amniotic fluid is also important to the developing fetus, and in pregnancy there are conditions where there is too much or too little amniotic fluid, which can adversely affect development. Greater than 2 liters of amniotic fluid is consistent with a condition known as polyhydramnios. It is typically caused by the inability of the fetus to swallow amniotic fluid, so this would occur with esophageal atresia, duodenal atresia, and anencephaly, where the fetus has no brain. It can also be caused by gestational diabetes, which leads to the fetus having polyuria. It can lead to lots of complications, including premature birth, pregnancy-induced hypertension, premature rupture of membranes, or abruption, as we just discussed. Management may include draining the fluid and indomethacin to reduce fetal urine output. On the other hand, less than half a liter of amniotic fluid is referred to as oligohydramnios. This can be caused in conditions where the fetus is not excreting urine properly. Examples include bilateral renal agenesis and posterior urethral valves in males. Of note, oligohydramnios can lead to pulmonary hypoplasia or Potter's syndrome. Fetal urine, which as we've mentioned is the main component of amniotic fluid, is critical for the development of fetal lungs, as it increases hydrodynamic pressure to expand alveoli. The lack of cushioning normally provided by amniotic fluid can also lead to physical deformities from mechanical stress.